Hey, welcome back to Not So Complicated, and today we are continuing our hematology and oncology series of pathology, and we are doing line by line analysis of step one first aid. So basically, we are doing this, okay? And we should have finished this portion in our second session, but with some reasons we couldn't, and today we are finishing this portion. This is very short and sweet, and after this finishing, we will tap into our gastrointestinal system of pathology. So stay with me. It's me, your motivated study partner, and we will cross USMLE Step 1, achieving greater than 260 plus. Okay, let's begin from myelodysplastic syndromes. Myelodysplastic syndrome is actually a stem cell disorder involving ineffective hematopoiesis. Hematopoiesis is actually the process of formation of red blood cells, or basically all type of blood cells, and it causes defects in cell maturation of non-lymphoid lineages. So we talked about lymphoid lineages, but this is a defect in cell maturation of non-lymphoid lineages, usually red blood cells, obviously. And the bone marrow blast, that is less than 20% versus greater than 20% in AML, is a different clinical feature. We'll talk about that in later. It is caused by de novo mutations and environmental exposure, example radiation, benzene, chemotherapy, risk of transformation to AML, which is acute myelogenous leukemia. We'll talk about that in our leukemia portions, and this is more common in older adults. So myelodysplastic syndromes are more common in older adults. And then here we have pseudo Pelger-Hewitt anomaly, where neutrophils with bilobed nuclei are seen. Neutrophils with bilobed nuclei. Usually the nuclei in neutrophils are multilobed, right? So neutrophils with bilobed nuclei, that is duet nuclei. You can remember like Hewitt anomaly has duet nuclei, right? In the figure right here, there is duet bilobed nuclei, and these are associated with myelodysplastic syndromes or drugs like immunosuppressants. Okay, let's go tap into the leukemia, so which is our main topic for today. And leukemia is basically blood cancer, and that even white blood cell cancer. It is unregulated growth and differentiation of WBCs in bone marrow that will cause marrow failure, and that will cause anemia, that is decrease in RBCs, infections decrease due to decrease in WBCs, and hemorrhage due to decrease in platelets. So basically, what happens is, since these all cells are formed in bone marrow, right? All type of cells are formed in bone marrow, and there is unregulated growth of WBC, and that unregulated growth of WBC will suppress the growth of RBCs and platelets. So since there is decrease in RBCs, that will lead to anemia, and then since there is decrease in platelets, that will lead to hemorrhage. Okay, so it usually presents with increasing circulating WBCs like malignant leukocytes in blood, although some cases present with normal or decreased WBCs. So leukemic cell infiltration of liver, spleen, lymph nodes, and skin are possible. So if there is leukemic cell infiltration in skin, we call it leukemia cutis. So there are types of leukemia. There are two different lineages for leukemia. One of them is lymphoid neoplasms, and then another one of them is our myeloid neoplasms, right? So basically, let's go to the lymphoid neoplasms. And in lymphoid neoplasms, here we have two main important tumor, and one of them is acute lymphoblastic leukemia, or ALL. ALL has two types, that is T cell ALL and B cell ALL, and then also chronic lymphocytic leukemia or small lymphocytic leukemia. So chronic lymphocytic leukemia is also called small lymphocytic leukemia. You have to remember this, because this is a confusing portion in our usual questions. And also here is hairy cell leukemia. We'll talk about this too. So in acute lymphoblastic leukemia or lymphoma, what actually happens is that it most frequently occurs in children. So the distribution is children. ALL is the distribution is children, and it is less common in adults, but if it occurs in adults, so it has worse prognosis. And T cell ALL can present as mediastinal mass. You have to remember this, presenting a superior vena cava like syndrome. So mediastinal mass, okay. So T cell ALL usually presents with mediastinal mass, and it is associated with Down syndrome. Peripheral blood and bone marrow have increase in lymphoblasts. Let's see in the figures. These are lymphoblasts right here. So peripheral blood smear, that is PBS findings, have increase in lymphoblasts. And TDT plus marker is positive. Marker for pre-T and pre-B cells is TDT plus, and CD10 plus is the marker for pre-B cells. So both of them are positive. TDT plus and CD10 plus, both of them are positive, and they are most responsive to therapy. They may spread to CNS and testes. So translocation, if there are two different types of ALL2. So if there is translocation between 12-21, it has better prognosis. 1-2-1, like remember it as a numerology. These kinds of sequences are better for our life, right? So 12-21 has better prognosis, but 9-22, which is Philadelphia chromosome, it is also a cause of CML, which is chronic myelogenous leukemia. We'll talk about that later. It has the worst prognosis. And in chronic lymphocytic leukemia or small lymphocytic leukemia, the age distribution is adult. So difference between acute lymphocytic leukemia, that is ALL, and CLL, main difference is in distribution, that is age greater than 60 years, it occurs in CLL. So you can remember, like, acute is instant, right? So children are instant aged, and CLL is chronic. So age, the more the age increases, the more the risk of developing CLL increases. So it is most common adult leukemia. So most common adult leukemia is CLL, right? So CD20 plus, CD23 plus, CD5 plus BCL neoplasm, all are positive, right? So this is often asymptomatic and progresses slowly, and smooth cells are present. So smooth cells, these are smooth cells right here. Smooth cells are the kind of cells that appear like they have just been blasted, right, like something just covered these. So that is how they appear, smooth cells. And in peripheral blood smear, obviously, autoimmune hemolytic anemia, and then CLL, crossed little lymphocytes, small cells. So they are crossed inside, like under a stone or something like that. So CLL means chronic lymphocytic leukemia, and also CLL means crossed little lymphocytes or small cells, right? So there is Richter transformation, which you have to remember right here. Richter transformation, that is CLL or SLL transformation into an aggressive lymphoma, most commonly diffuse large B cell lymphoma, DLBCL. So this is Richter transformation. Richter transformation is that chronic lymphocytic leukemia will turn into aggressive lymphoma, which is most commonly diffuse large B cell lymphoma. So that is what it is. And in hairy cell leukemia, the distribution is adult males. It is a mature B cell tumor. Cells are filamentous hair-like projections, obviously by name it says. So there should be hair-like projections in cell, fuzzy appearing and LM, right? So here you can see in figure C, like a hair strands. These are like hair strands in here, right? So that is how it seems in LM. And also peripheral lymphadenopathy is uncommon in this case, and it causes myelofibrosis, which is dry tap in aspiration. There is no cell lineages that can be presented in a wide manner. There are no cell lineages that can be presented in bone marrow aspirate, which is called dry tap, right? And patients usually present with massive splenomegaly and pancytopenia. Stains are trap stains. Trap stains, that is tartarate resistant acid phosphatase positive, and also trapped in hair resuscitation, right? So trap stain, largely replaced with flow cytometry, and it is associated with BRAF mutations. The treatment include purine analogs, cladribine, and also pentostatin. So that is how we complete our lymphoid neoplasms. And now we will tapping into myeloid neoplasms. There are two main types of myeloid neoplasms, that is AML and also CML. CML is chronic myelogenous leukemia. It is often associated with Philadelphia chromosome. And then we will talk about myeloproliferative neoplasms and polycythemia. So in acute myelogenous leukemia, what happens is the median age of onset is 65 years, right? So all rods are the characteristic features of AML. All rods, here you can see these all rods. These are the characteristic features of AML. And then myeloperoxidase positive cytoplasmic inclusions seen mostly in APL, formerly M3 AML. There is a FAB classification of AML with M1, M2, M3, M4, M5 kind of level. And then you can look at that in Robbins and Crotton textbooks, right? So there is increasing circulating myeloblast on peripheral smear, and it may present with leukostasis, which is capillary occlusion of malignant and non-distensible cells that will lead to organ damage. So leukostasis, which is a capillary occlusion by malignant non-distensible cells, which causes organ damage, right? So if there is occlusion of blood vessels, that will lead to the decrease in blood supply, oxygen supply, nutrient supply, right? And that will obviously lead to the organ damage. This is very common pathophysiology. The risk factors of AML include prior exposure to alkylating chemotherapy, radiation, benzene, and myeloproliferative disorders, right? And also Down syndrome, typically acute megakardioblastic leukemia, formerly M7ML. And APL, that is translocation 15 to 17, responds to all transretinoic acid, vitamin A, and arsenic trioxide, which induce differentiation of promyelocytes. And DIC is common presentation in AML. Remember this. DIC is a very common presentation in AML. And in chronic myelogenous leukemia, here are symptoms. The symptoms, like the peak incidence is in 45 to 85 years of age. The median age is 64 years. In AML, median onset is 65 years, and CML, median onset is 64 years. And in these 5 tumors of leukemia, like these 5 leukemias, only ALL presents in children, and all of that is present in older age. So in CLL also greater than 60 years, here is a leukemia adult males, and AML greater than, like, median onset is 65 years, and in CML median onset is 64 years, right? So CML is due to Philadelphia chromosome, that is translocation 922 BCR AVL. We have to remember this is a very much commonly asked question in leukemia portion from on USMLE Step 1. And also myeloid stem cell proliferation occurs. It presents with dysregulated production of mature and maturing granulocytes, example neutrophils, metamyelocytes, myelocytes, and basophils. These metamyelocytes, myelocytes are the cell lineage from which the neutrophils come, from which these leukocytes come, right? So they are basophils. There are basophils too. Here you can see these all abnormal cells. And then the patient usually presents with splenomegaly too. So it may accelerate and transform into AML or ALL, which is also blast crisis. So it responds to BCR AVL tyrosine kinase inhibitors like imatinib. It responds to that because BCR AVL fusion gene is also the culprit for this case. That is how we complete our neoplasms like leukemias. Now we will talk into myeloproliferative neoplasms, and that include polycythemia vera, which is primary polycythemia, and then essential thrombocythemia, and then myelofibrosis, right? So here we will also talk about these all differences, like the findings difference in these cases. So in myeloproliferative neoplasms, what are they actually? They are actually malignant hematopoietic neoplasms with carrying impacts on WBCs and myeloid cell lineage. That is what myeloproliferative neoplasms are. So the examples include polycythemia vera. Polycythemia vera is actually primary polycythemia, and there is a kind of secondary polycythemia too. Secondary polycythemia usually occurs in a case of hypoxia, because since there is less amount of oxygen supplied in the body, and that will be sensed by our kidneys, and the kidneys will release EPO, that is erythropoietin, and that erythropoietin will increase the concentration of RBCs by increasing the formation, right? So that is how secondary polycythemia occurs. But the primary polycythemia vera has a different pathogenesis, which is disorder of RBCs, usually due to acquired Janus kinase 2 mutation. So JAK2 mutation is a basic cause, the most common cause of polycythemia vera, and it may present with an intense itching after shower, that is aquagenic pruritus. This is very most commonly presenting symptoms in the case of primary polycythemia, and the disease is asked like this in our clinical cases. So you have to remember this. If a patient comes with an intense itching after shower, then you have to consider the case of polycythemia vera in the first sentence, right? So it is also called aquagenic pruritus. It is rare, but classic symptom is erythromelalgia, that is severe burning pain and red-blue coloration due to episodic blood clots in vessels of extremities associated with hyperviscosity and thrombosis. Example, pulmonary embolism, deep venous thrombosis, and Burns-Irving syndrome. Burns-Irving syndrome, we will talk about this in which case? In our gastrointestinal pathology, which we will be starting after finishing this session. Okay, so yeah, by far you have to know that we will be finishing our pathology, entire pathology first, and then only we'll tap into other subjects, because 42% of questions in USMLE Step 1 is from pathology. So I have focused in that. There is decrease in EPO versus secondary polycythemia, where there is increase in EPO, but in primary there is decrease in EPO, that is negative feedback, and also it presents with endogenous or artificially, that is increase in EPO. The treatment is phlebotomy, hydroxyurea, ruxolitinib, and actually this ruxolitinib is that is Janus kinase half inhibitor. Okay. The another cause is essential thrombocythemia. What happens is characterized by massive proliferation of megakaryocytes and platelets. Okay. It's a proliferation of platelets, right? So the symptoms include bleeding and thrombosis, and blood smear shows markedly increased number of platelets, which may be large or otherwise abnormally formed, that is erythromelalgia can occur. You can look at these figures in A. This A figure is associated with hyperviscosity and thrombosis. This is associated with hyperviscosity and thrombosis. This is in the case of primary polycythemia vera. And this cells right here in the case of essential thrombocythemia. And this is erythromelalgia that is occurring in here. And the third symptoms is myelofibrosis. It is atypical megakaryocyte hyperplasia, and also increase that will lead to increase in TGF beta secretion, that is a tissue growth factor beta secretion, that will lead to increase in fibroblast activity and thus obliteration of bone marrow with fibrosis. It is associated with massive splenomegaly and also teardrop RBCs. This here, this RBCs like teardrop dacrocytes, we also call them dacrocytes, and bone marrow cries because it is fibrosed and is a dry tap. So in bone marrow aspirate, we see teardrop cells. It is due to mechanical stretching of these RBCs, like mechanical leaking out of these RBCs. That is what it occurs actually. So there are differences between different conditions in here: polycythemia vera, then essential thrombocythemia, then myelofibrosis, and chronic myeloid leukemia. There are differences, right? The RBCs in the case of polycythemia vera, they increase, and in WBCs also increase, in platelets also increase, and then Philadelphia chromosome is negative in polycythemia vera, Janus kinase 2 mutation is positive. So all three cells like RBCs, WBCs, and platelets increase in polycythemia vera. But in essential thrombocythemia, RBCs can be normal, WBCs can be normal, so it is exclusively for platelets. So platelet count is increased, Philadelphia chromosome is negative, and Janus kinase 2 mutation is positive in 30 to 50% of cases. In myelofibrosis, RBCs are decreased due to dry tap, obviously the fibrosis in the bone marrow. WBCs is variable, platelets is variable. So Philadelphia chromosome negative, but Janus kinase 2 mutations is positive in 30 to 50% cases. And in CML, that is chronic myelogenous leukemia, RBCs decrease obviously, WBCs increase, and also platelets will be increased. There is Philadelphia chromosome positive, but Janus kinase mutation is negative. You have to remember this all. Okay. There is a difference between leukemioid reaction and chronic myelogenous leukemia. This is a very favorite question in MBBS also. in your board exams, this will ask the differences between leukemia reaction and chronic myelogenous leukemia. So the differences are that leukemia reaction is reactive neutrophilia greater than 50,000 cells per mm cube. Reactive neutrophilia, because it is a reaction to normal, like infection, some kind of infection. It is a reaction kind of infections, right? So in chronic myelogenous leukemia, it is a myeloproliferative neoplasm, and it is positive for BCR-ABL fusion gene. And neutrophil morphology, there is toxic granulation, and dolly bodies are present. Cytoplasmic vacuoles are also present. So dolly bodies are present in leukemia reaction. And neutrophil morphology, pseudo-Pelger-Hewitt anomaly is present in CML. Pseudo-Pelger-Hewitt anomaly, which is also duet bilob neutrophils, bilob nucleus neutrophils are there. And Lapis score of leukemia reaction is increased, and then Lapis score is decreased. Lap enzyme is decreased in malignant neutrophils. And eosinophils and basophils are normal in case of leukemia reaction, but in CML they increased. So let's see polycythemia. What is polycythemia actually? We'll talk about this and we'll finish this session right here. This is gonna be a very short session. The polycythemia, these are relative. The polycythemia can be relative, appropriate absolute, inappropriate absolute, and then polycythemia vera. There are 4 types for polycythemia. So in relative, there is decrease in plasma volume. So since there is decrease in plasma volume, there is increased concentration of red blood cells that will cause polycythemia. RBC mass is normal, oxygen saturation normal, EPO levels normal, because there it is not a case of any compensatory mechanisms or destruction or decrease in amount or the loss kind of situations. It is simply due to relative loss of plasma volume, and thus the concentration of RBC increases. It occurs in the case of dehydration and bonds kind of things. And appropriate absolute, the plasma volume is normal, RBC mass is increased, oxygen saturation is decreased, EPO levels are increased. It actually occurs in the case of lung disease, congenital heart disease, high altitude, obstructive sleep apnea. In all these cases, there is hypoxia, that is decrease in our oxygen saturation, and also partial pressure of oxygen will decrease to less than 60 mm of Hg, and that will be sensed by the kidneys, and those kidneys will release this EPO, that is erythropoietin, and that erythropoietin leads to erythropoiesis and thus increase in RBCs. That is why there is increase in RBC mass and a decrease in oxygen saturation because of these diseases, obviously. And inappropriate absolute, plasma volume is normal, RBC mass will still be increased, oxygen saturation is normal, EPO levels are normal, increased. Why that occurs? If there is exogenous EPO, like athlete misuse, also called blood doping or doping, and also androgen supplementation, that can cause exogenous EPO. So those exogenous EPO will lead to increase in erythropoiesis, leading to increase in RBC mass. And inappropriate EPO secretion is in malignancy, that is renal cell carcinoma and also HCC, hepatocellular carcinoma. In these cases, EPO levels can rise, and that will lead to increase in the RBC mass. And primary polycythemia, there is increase in plasma volume, there is increase in maximum increase in RBC mass, there is normal as oxygen saturation, and EPO levels are decreased. EPO levels are decreased in primary polycythemia vera due to negative feedback, as I had talked earlier, due to negative feedback suppressing renal EPO production. So chromosomal translocations, these are out of all chromosomal translocations, these here are very high yield, and you have to remember each of these chromosomal translocations without a single doubt. So translocation 8 to 14 occurs in Burkitt lymphoma, MOIC mutation. Way to remember here is that translocation 8 to 14, right? So 8 can be pronounced as it. So this is Burkitt or Burkitt lymphoma. So chromosomal translocation 8 to 14 in Burkitt lymphoma. 11 to 14 in mantle cell lymphoma, cyclin D1 activation. 11 to 18, 14 to 18, and 15 to 17. All of them can be present in marginal zone lymphoma and follicular lymphoma, BCL2 activation, and also in APL, which is the M3 type of ML in FAB classification. And 922 Philadelphia chromosome. Out of these two, the most Remember, translocation is Philadelphia chromosome is in CML, chronic myelogenous leukemia, BCR, AVL hybrid is occurs, and ALL, which is less common, Philadelphia cremal. See, you don't have to remember like this. This is a very important. You should have this in a tip of the tongue, right? You do not need any mnemonics to remember this. So in notes, the heavy, like immunoglobulin heavy chain genes on chromosome 14 are constitutively expressed. So when other genes, example CMYC or BCL2, are translocated next to this heavy chain gene region, they are overexpressed. That is why there is coexistence of these mutations, right? So the last but not least of hematology and oncology of pathology, we have Langerhans cell histiocytosis. You can see in the figure. So what is it actually? Langerhans cells histiocytosis. These are a collective group of proliferative disorders of Langerhans cells. What are Langerhans cells? Langerhans cells are antigen presenting cells normally found in the skin. So basically, if any antigen is invading our normal natural continuity of our body, so Langerhans cells, which are antigen presenting cells, will present them to the dendritic cells or natural killer cells, right? So these Langerhans cells, if there is proliferative disorder, like that, if there is increase in number of Langerhans cells, that is called Langerhans cells histiocytosis. It is present in a child as lytic bone lesions and also skin rash or as recurrent otitis media with a mass involving mastoid bone. So there is a mass involving mastoid bone. This is particular feature, you have to remember this. And cells are functionally immature and do not effectively stimulate primary T cells via antigen presentation. Cells express S100 and CD1A. Burbic granules, this is high yield. You have to remember this. Here you can see Burbic granule, which is tennis rackets, a rod-shaped EM. You have to remember these things. Tennis rackets are rod-shaped on EM. You have to remember this. EM is electron microscopy. Burbic granules or tennis racket cells in electron microscopy is a characteristic feature of Langerhans cell histiocytosis, and that is how we complete our hematology and oncology session. We'll be starting our gastrointestinal pathology, which is a very huge topic. There is 26 pages in USMLE Step 1. So basically, first aid. So basically, it will take 3 sessions for that to complete. We will do that from tomorrow. And if you are new here, subscribe and let's build a community where we finally crack USMLE in that level that we get the residency we want. So thank you for staying with me if you are still here, and subscribe for next videos. Stay tuned. Thank you.